you remember with adults and with kids, you don't want to just check the radial pulse for a minute. You want to check the apical pulse because a lot of these kids have different dysrhythmias going on, and that apical pulse will be different from the radial pulse. So you want to listen for a full minute, the apical pulse. So these patients and the parents actually get sent home with a stethoscope so they can listen and they're taught how to check that pulse correctly. I also want to teach them about the narrow therapeutic range and the toxicities, which are the bradycardia, dysrhythmias, nausea and vomiting. You teach these parents how to use a dropper. Sometimes they don't understand exactly how that works. We also have to teach them how to calculate the dose, how they give it every 12 hours if they miss a dose because they just forget or they were out or something happened. We want to remind them not to give an extra dose. One more thing, again, is just having them learn how to check the apical pulse and to return that demonstration before that their patient's discharged so they fully understand how to give DIG and the consequences of what a side effect looks like from DIG. 2-month-old child has a known cardiac defect and is in congestive heart failure. Which assessment finding indicates the nurse a toxic dose of DIG? Briefly, we're going to talk about the different cardiac disorders. There's 3 of them that we're going to discuss, and that's endocarditis, rheumatic fever, and Kawasaki's disease. Usually these disorders occur at birth, and a heart that's either normal before or they can be a congenital heart defect that's already happened. So if a patient is born with a congenital heart defect, they're going to be more at risk for developing bacterial endocarditis, rheumatic fever, or Kawasaki's disease. Endocarditis is a bacterial infection, and I've written these on the board trying to keep these straight in our mind because endocarditis, just what it sounds like, it's going to affect the endocardium, which is the inner lining of the heart, and it's also going to infect the valves. So the main organisms that cause endocarditis is strep, staph, and candida. Usually the organism is going to enter the bloodstream through any site of infection. It attaches to the inner lining of the heart. Your book says it forms these types of vegetations, and then it can start causing deposits of fibrin to build up and platelets. So these patients are at risk for thrombi and embolisms. Next, these lesions can spread, and they can actually break off from the inner lining of the heart and travel other areas. So that's when it becomes more of a medical emergency at that point. In order to diagnose, we obviously have to identify which agent caused this infection. Was it staph? Was it strep? What exactly caused it? And treat that. There are some other ways that you can detect endocarditis, but for our purpose, we're going to look at trying to identify through blood cultures the causative agent. So as far as manifestations, it's going to look like other type of bacterial infections. You're going to have a low-grade fever. It's going to have a slow onset. But specific for endocarditis, they have this thing what's called splinter hemorrhages, and that is thin black lines underneath the nails. And that is due to the, what we talked about a couple slides back about causing the different emboli and being at risk for different kind of hemorrhaging. There's also Janeway spots, and these are little hemorrhages on the areas of the palms and the soles of the feet. And also when we think of hemorrhaging, we also think of petechiae, which are those superficial, small, purple bruises. And that's usually found on the inside the mouth, on the oral mucous membranes. So to treat endocarditis, we're going to give high doses of antibiotics, usually for 2 to 8 weeks. Sometimes these antibiotics can be administered at home and the patient doesn't have to be hospitalized. In order to prevent endocarditis, if a patient has been born with a congenital heart defect, we're going to give prophylactic antibiotics. And usually that is for things like dental procedures. Some kids have to actually come into the hospital to have teeth pulled or different kind of mouth procedures done. So if they have a congenital heart defect, or if they're at risk for endocarditis, we're going to give them prophylactic antibiotics. And the drugs of choice are listed down there. In lab today, we use penicillin G, which is another type of amoxicillin or ampicillin. The second acquired cardiovascular disorder we're going to talk about is rheumatic fever. And to keep that one straight, it's going to be an inflammation of the joints, skin, brain, any kind of connective tissue. This specific type of disorder usually occurs after someone's had a strep infection. If you remember back to respiratory, we had a slide that said sequelae of strep. And we mentioned acute glomerulonephritis. We also mentioned rheumatic fever. So here's where rheumatic fever comes back in. And usually this is a result of either the patient, maybe they didn't take their antibiotics correctly for the 2 weeks straight, or maybe the antibiotics were not effective. And they develop weeks later, they can develop rheumatic fever or acute glomerulonephritis. So a complication from rheumatic fever is actually having valve damage. To diagnose, we look and see if the patient had a history of a strep infection recently or a history of scarlet fever. We're going to look for the elevated strep titers, which if you remember that's what we look for to see if a patient has strep throat. There's also what's called the Jones criteria, and that was established by the American Heart Association. The Jones criteria is a little tricky. The child either has to, there's a list of major symptoms and there's a list of minor symptoms. So the patient either has to have 2 major or 1 major and 2 minor in order, with a recent strep infection, in order to have a diagnosis of rheumatic fever. So that I just listed a couple here, the major and the minor, that they would look at, along with the recent strep infection to get diagnosed. So 2 major or 1 major and 2 minor. So further treatment could be penicillin for these patients with rheumatic fever. The unique thing with rheumatic fever and Kawasaki's is that we're going to treat these patients with aspirin. You may remember what the bad side effect from aspirin is. We're also going to give prednisone because remember this is an inflammation of the joints and skin. So sometimes these patients have arthritis. They can't move around very well because they're so inflamed. Sometimes rheumatic fever can last up to 3 months. So we're going to encourage bed rest. Just like with some of our other heart conditions, if the patient is at risk for rheumatic fever, we can give prophylactic IM injections of penicillin G. If a patient has had rheumatic fever, they are susceptible to having rheumatic fever again and again the rest of their lives. So they have very long treatment, anywhere from 5 years until they're 18 years of age. They can be on different antibiotic therapies for things. So if they're going to have any kind of GI procedure or dental procedure, they're going to need prophylactic antibiotics to prevent rheumatic fever. A 14-year-old child is admitted with a diagnosis of rule-out rheumatic fever based on the Jones criteria the nurse assesses for. Well, I have to go back to the slide with the major and minor symptoms listed. Remember that rheumatic fever occurs after a strep infection. So we're going to test them for strep titers. So it would be D, based on the major and minor. All right, the last disorder we're going to talk about is Kawasaki's disease. And this can involve multiple systems of the body, causing vasculitis, which is basically an inflammation, if you remember, of the inner lining of the arteries and veins. So there's several different phases of this disease. At first, these patients are just going to present with a fever. They may have swollen hands and feet, because again, it's vasculitis. They can have enlarged lymph nodes. This is going to progress to cracking lips, peeling of the skin, and the tips of the fingers and toes. And then eventually, once they receive treatment, their manifestations are slowly going away, but they're still going to have abnormal lab results. This next picture shows you a little bit about that second phase of the cracking lips, hands, and feet. It looks pretty painful, but it's actually painless. In order to diagnose, we look for a fever that's been greater for 5 days that has not responded to Tylenol. We're looking at edema, looking at that redness of the palms and soles of the feet, looking for that peeling of the skin. These patients can also have the bilateral conjunctival infection, which is basically like a pink eye. They can have a strawberry tongue, so you want to think of any area of the body, especially superficial, like our hands and our feet, that that inner lining of the arteries and veins is so inflamed that it's causing even a decrease of oxygen to reach those different superficial kind of cells in the peeling. There can also be rashes involved, as we saw with that one slide. So similar to rheumatic fever, we're going to treat with aspirin. And the main reason why we're treating with aspirin is to reduce this inflammation, because we have vasculitis, and that's our main issue that's being involved in this Kawasaki disease. So even though these patients have a fever, we're more gearing it towards the inflammation. So after their fever has gone down for about 72 hours, we can slowly start to wean that aspirin dose. So it's based on that child's response to the aspirin. We can also give Lovenox and Plavix because we're concerned about this vasculitis affecting their coronary arteries. And if that occurs, they're at risk for aneurysms and all sorts of other issues going on. So as far as it staying superficial with the hands and the feet and the cracking of the skin and lips, that's better than it progressing to coronary arteries. We can also give gamma globulins, which is IVIG, and that just helps to prevent the occurrence of a coronary aneurysm. So we're going to frequently assess these patients for congestive heart failure because we're concerned about it affecting the coronary arteries. We're going to give them small and frequent meals. Passive range of motion to the extremities because they have that vasculitis in their legs as well. They may not be able to walk and play and move as well. We can give cool compresses because we have those superficial peeling of the skin in the mouth and the toes. Like we talked about, complications can be aneurysms, signs of aspirin therapy, such as side effects like GI, bleeding, Ray's syndrome that we talked about, and there can also be side effects of IVIG therapy, and that's going to be increased blood pressure. So when we have patients that present with Kawasaki, we want to teach the parents about good skin hygiene. We don't want to use any kind of soap or lotion that's going to have a strong smell to it. We want to give high-calorie liquids, low cholesterol diets. Obviously, we don't want to give aspirin before we've checked the temperature. We want to give aspirin after we've checked the child's temperature. Again, we talked about using passive range of motion. Usually, if parents will do that in the bathtub, that will help increase the flexibility. We have mentioned here that live immunizations are going to be on hold for a while, and that's because they're at risk for their immune system is compromised at this point. So if we give them a live immunization, they're not going to tolerate it well. And they can also have signs and symptoms of an MI or cardiac ischemia because of the coronary aneurysms. So a toddler with Kawasaki's disease is ordered to receive aspirin therapy. The nurse anticipates that medication therapy with aspirin will follow which principle? B, that's right. We're going to base it on the child's response. After they are 8 feet wild, we can change the dose. But what are we mainly giving aspirin for in Kawasaki's disease? Inflammation, that's right. When we come back after the combo hour, we'll go over preschoolers. Anybody has any questions, please come to the office. I got it.
Maybe like the